she was started on Suboxone when she was incarcerated in the fall, and then when she was released and entered adult treatment court, she was referred to us to continue the Suboxone, which she found helpful. I don't think I included on here that she is on 12 milligrams a day, and I think that's pertinent. So for the first couple of weeks that she was in our program, she was testing positive for fentanyl, and not admitting to using. But anyway, since then, she has not had any fentanyl or any other illicit drugs in her system. But the interesting and perplexing thing to me is that since she enrolled in the program up until this past week, her urine confirmations, which we send out every week, have had a reverse ratio of, well, either a reverse ratio of buprenorphine to norbuprenorphine, or almost no detectable norbuprenorphine, no detectable, almost no detectable metabolite. We recently had, or actually for about the past 2 weeks, she's been witness dosing during the weekdays, not over the weekend. And in spite of that, her confirmations that we send out continue to have that very teeny ratio. And the day report center where she attends also sends her urine out daily, and the ratios there are the same. She's witness dosing and at the day report center. We had her come in and witness dose with us for 5 days when this first started happening, but we did not send out her urine, so it was kind of a kind of fell down on that at that time. But since then, we've been working with the day report center. She is very engaged in group. She's very pleasant. She when I tell her all this, she just sort of makes the face I just made. She just sort of goes, she says she's taking her medicine as prescribed. And so I am really perplexed by this. I even went so far as to talk to our case manager who does her screens, and is she really seeing her when she's screening? And I won't get into details, but what she described to me that she's witnessing during her screens sounds like she would really have to be a master of illusion to be either having a strip that she's urinating on, or to be substituting some other urine for her own. Comorbidities, dental decay, and anxiety. She's taking Buspar, I believe, for her anxiety. So my question is, are there people who metabolize buprenorphine differently, where the metabolite wouldn't be detectable? Or is there any other explanation? I just cannot get a handle on this. And she is at 56 or 63 days now in our program, so she's about to, in a month, she'll be graduating to our biweekly. And I just don't feel like I've never seen this before, and I don't really understand it.
Excellent. Thank you so much. Does anybody have any questions? Go ahead. I see you unmuted, Tony.
Yeah, Jen, besides the Buspar, is she on any other medication, and does she have any liver issues?
Just the Buspar, and no liver issues that I'm aware of. I haven't looked back at her blood work from when she was enrolled. I could probably do that while we're on now, but she does not have hepatitis C, and as far as I know, she doesn't have any liver other.
Jen, when she was positive for fentanyl, was it norfentanyl or fentanyl only for the first 2 weeks?
That's a great question. I'd have to look that up, and I could probably do that. I think it was, but I'm pretty sure it was fentanyl.
Okay.
Any other questions before we go into some recommendations or further discussion? All right, feel free to unmute or raise your hand. There are a lot of us in here if you want to suggest anything.
One possibility would be to get genetic testing to see if she doesn't, express the gene for the P450 enzyme, or in a normal way.
And there are people who are fast metabolizers. So when we did some genetic studies multiple years ago, I'm just trying to look at the papers. I mean, if you look up variations if you kind of Google variations in buprenorphine metabolism, there are definitely people who metabolize at a faster rate than others, and often they'll actually talk about we say it lasts in your system for a long time, and these are the people who are like, or these could be the people that say, actually, I get some withdrawal, and it may be in fact because they're metabolizing it more quickly. I don't have my hands on the literature, but you could certainly look it up.
Thank you so much, Laura and Jeremy. Jeremy, Dr. Heath.
Other Jeremy, no. I was thinking kind of the same lines as Dr. Hirschler, that the boost bar really shouldn't be really affecting the metabolism too much of it. But yeah, I don't know if the genetic testing would show exactly what the level of the CYP3A4 would be. Sometimes we put a little bit too much into those genetic tests and expect it to tell us everything and what medicines will really work, and depending on what you get. I know Medicaid, depending on what insurance this person has, will cover it. Interesting, boost bar is actually metabolized from 3A4 too, so I don't know if she gets like overly drowsy or anything, and low doses do much for her. When you send it off, like what kind of levels are we talking about, like nanograms? Do you have like an example of like the
Yeah, let me look. I just pulled her chart up and and just more information. Originally, when she was screening positive for fentanyl, it was fentanyl, not norfentanyl. And that went on for about the first month that she was in the program. And then levels, the bup is 3,030 nanograms. This is from just a couple of weeks ago or a month ago, and the norbup was 24.
Hmm.
And the Buspar she just started about a month ago. I'd have to dig around to see if she had drowsiness with that. I could look.
fairly consistent, that just low doses or low norbup every time around the same levels.
Yeah.
That's really
Yeah.
interesting.
Yeah.
I mean, she's clearly taking it, so it's not all, and the observed drug screens. I mean, at face value, you'd say, oh, they're dipping it, but yeah, she's not. It's pretty wild. You might want to write this one up. Jim.
Oh, okay.
How about that?
Interesting. Okay.
Yeah, my hopes are that in like 5 years, maybe we'll have more of these types out there to have a little bit more clarity on it. Because I had some questions, you already answered them. I was wondering, hey, if we're witnessing dosing, are we witnessing the urine collection? And the answer was yes. I mean, technically, maybe somebody could also be testing for naloxone. If there's further concern with the combo product, if it was IV or just dropped in, spiked in.
Yeah. Yeah, the naloxone is in there too.
Yeah, so they're doing that. As far as other medicines, Buspar, Jeremy's clearly a pharmacology expert there. He's banging a drum there.
What I know is from you there, Mark.
I'm going to hesitate on this. I did pull up a PGX reference relevant to this. I will share it in the chat. there's a disclaimer. You're going to have 25 more questions if you read it than when you walk into it. So do with it as you will. I will send it here. We go. One thing on the dental decay came up there, was that, chicken or egg, was that from the bup naloxone or somehow before, with the occasional?
I think it was from before, and I don't know the details on her previous meth use, but I have sort of assumed that it was related to that.
Because it just, I think it's been over a year now with the headlines. Amazing what ends up in headlines, but with the buprenorphine naloxone combo products, that being a concern. General mitigation, either switching to solo, or rinsing mouth after use, for the buccal, of course, sublingual, and then waiting an hour or so to brush teeth, if that's even applicable for any human. So, a couple tidbits there.
Thanks. Just, I know we have another case, but just for the sake of conversation, my other person who I said I have a similar situation, his actually, well, it's hard to say this quickly, but anyway, he has been also testing with a kind of an inverse ratio in his bup, and most recently he submitted, or he gave us a sample that we submitted for testing beyond screening, and it actually was returned as not human urine, and had cocaine in it as well, which I was like, oh gosh, how did that happen? But at any rate, so with him, it looks like there's something inappropriate going on. I still have to look into that. But with this lady that I presented today, I feel like we've looked at everything. So this is interesting feedback, and I'll maybe see if she'd be interested in genetic testing.
Awesome. Thank you so much. Definitely keep us updated on the other one too. We appreciate that, Jen. All right. Dr. Bow, are you available now? You ready?
Yeah, but I must apologize. My nanny is sick, so I have 2 kids and they're going to be crying in the background. If y'all cool, I cool.
We cool.
Okay.
Give me
Okay.
1 second. I'll share it for you. Okay.
Okay, thanks.
Of course.
Okay. Okay. So the reason why I presented this case is because this lady, she's been in our clinic for a while. She's 38 years old. She's been incredibly compliant with us. But unfortunately, she's been having a difficulty with one of her comorbid problems, which is actually Crouzon's disease. So this lady has been with us for about 4 or 5 years, and her primary diagnosis was opioid use disorder severe. We initiated her on buprenorphine, naloxone. She's been fantastic for 4 years, no relapses. Unfortunately, comorbidly, she also has a seizure disorder, and she has a Cary malformation. So what's been going on with her over the past 3 to 4 years, she's been complaining of worsening headache, nausea, vomiting, inability to eat, also to having lots of problems with her dentition. Okay, and all of these actually have to do with her problem with Crouzon syndrome. Now, she was not diagnosed as a child. She was diagnosed as an adult. And what Crouzon syndrome is, it's a craniofacial dystosis where you have the sutures of your skull. What that happens, it fuses pretty quickly. So your facial bones and your face never get a chance to fully form, and you don't look like a normal adult. All right. In addition to this, you have ocular problems because you can imagine this brain squeezing your eyes forward. You have proptosis. You can have problems with the okay, baby, with the nerves in your eyes, and also you have problems with dentition because of it. So she went to see a look at him picking up my binoculars. She went to see a neurosurgeon inside our department, and the neurosurgeon was referred by her PCP. The neurosurgeon did an MRI and found out that, oh my God, in addition to this Crouzon syndrome, she now has brain herniation called Cary malformation. And we have pictures attached to this so you can kind of get a picture of what I'm talking about. So this Cary malformation is causing the bottom part of her brain, the cerebellum, the force to be pressed down. So that's what's causing all these headaches. And he actually recommended for her that she gets urgent neurosurgery consultation up in Morgantown. Now, unfortunately for this lady, because of her socioeconomic issues, she can't get to Morgantown for this assessment. And because of that, she's having ongoing pain. The pain clinics that she's seen, they said they can't do anything for her. And what I'm worried about is that she's going to eventually need to have to come off of buprenorphine and onto opioids just to control the pain. And so what I brought her to the group is I need y'all help in figuring out how can I get this lady to Morgantown to get properly evaluated, because unless you're a neurosurgeon who is specialized in Cruzons or really seen it, you actually have no idea what to do. In addition to that, what can I do in terms of her pain, right? I know this is acute and chronic pain. It's going to be chronic. It's not going to get any better. Even if she has surgery, who knows what can happen. So that's what I'm dealing with. So comorbidly, other things she's dealing with, she had full dental extraction. She's now having issues with her eyes. And comorbidly, she also has issues with her strengths. So around C4 level, she has this, it's a cyst on her spinal cord, which her doctors think is also going to cause a problem. So that is the case. And I am wide open for, okay, baby, for any suggestions, what you all think. In particular, I would love it if we could figure out a way how to get her to Motown to see the neurosurgeon. Any feedback, please?
Thank you so much. Anybody just go ahead and chime in, and thank you so much, Dr. Bell. Your baby's adorable.
One idea is to use spiritual services like a church, a community church, or volunteer organizations that might be able to provide transportation. I don't know if she's involved in anything like that, but I know in our community, churches will often get involved with people who have special circumstances.
If she
She is involved with her church, but unfortunately, she's someone who suffers from socioeconomic insecurity, and so do her church members. She's already reached out to them as well as her AA groups and her NA groups, because she actually helps, I guess, chair some of those, and they can't help her.
If she has Medicaid, Medicaid will cover transportation for her to get to Morgantown.
That's what I was
True.
told, but apparently it's just for opioid use disorder treatment. Is that right or incorrect? Can she get there?
No,
for
they should be able to, Medicaid should be able to get her transportation for any medical condition. As far as I know. I mean, maybe I'm wrong. I don't know.
There's two different ride services, because what Logistic Care does any medical appointments. Then there's the opioid, SOR related transportation. That's more for opioid treatment, but for any appointment.
Yeah, it's
they have 7
Logistic.
days.
Yeah, Logistic Care. I think it's called Motive Care now.
Yeah, they keep changing.
Yeah.
Motive Care will pay for one medical trip per day. So if it was to the clinic plus to the Morgantown, they wouldn't pay for both, but they'll pay for one.
Thank you so much for that. Dr. Husted, you unmuted again?
No, I remuted.
Tricky.
Remute, I like that. There was an important comment there from Sheila Kelly that her MCO care manager could help with arranging services. Dr.
Yeah, okay, thanks.
That's excellent. We can provide that information to you too.
Yes, I need that.
Of course, no worries. Any other questions or comments? Thank you so much for the case as well. Go ahead, Dr.
What do you
Bell.
all think about the pain though? Because what can I do about that?
Yeah, so that might be something a neurosurgeon would be better equipped to look at, what like in the headache clinic here at WVU, they use all sorts of things other than opioids or Suboxone, like Topamax or SNRIs, or there's all kinds of medicines that are used for headaches. So you might be better off with a neurosurgeon helping with that.
Elizabeth, are there any, I don't think there are any neurosurgical echoes, are there?
We're starting to get into MS and like neurodegenerative diseases. We just began that one, but that might be a good resource. Yeah.
Plus, they probably need to see her directly too. I was just trying to think if telehealth may be an option.
Yeah, they probably, I'm not sure, but that's a good idea. Never know for sure. All right, are we good on this case, Dr. Bowe? You can put the Thank you so much. All right, we'll go into the didactic portion for everyone. Cynthia, are you ready? Did you want me to share your slides? Oh, before we begin, I'm sorry to interrupt, my bad. We did have a case come in, but we don't know who it belongs to. If somebody want to claim it, I can share it. We did it, but it did not have any type of like case attached to any individual or email or anything for us to know. It's just like we thought it was Dr. Bowe, but it's not. It's just like a Eagle syndrome's mentioned in it. Oh wait, is that the one we just said? So sorry. My bad. This one. No. It's a ghost case. All right. We just want to make sure no one wants to claim it. That's fine. Oh my gosh. All right. Cynthia, did you want me to share your slides? I give you capability to do so too, but you would like me to?
Yeah, if you could share them, that would be great. Great. Do you just want me to start? All right, great. Thanks, Elizabeth. And thanks to Tony for inviting me today. I'm Cynthia Pursley. I'm the Cabinet Secretary for the new West Virginia Department of Human Services. And as you all know, last year, House Bill 2006 caused the old DHHR to be split into 3 departments. And that occurred officially on January the 1st. However, the 3 new department secretaries have been on the job since about July the 5th, and we have been working both together as well as separately with our departments and our department leadership, and I'm getting ready for that split that occurred on January the 1st. So I'm going to talk to you very briefly about my priorities for the department. I'm not going to have time to talk about all the priorities. It's a very large department, but just give you some insight into what this department looks like. And Tony sent me some questions, and I'll hopefully be able to either weave these into my presentation, or I'll go to the questions afterward and try to address those as well. So Elizabeth, if you could advance the slides one. So this is the Department of Human Services. This is our org chart. The specific goal for me was to have a relatively flat org chart and leadership team, with the span of control being relatively narrow. I think one of the criticisms of the former DHHR was that there were way too many people reporting to cabinet secretaries and to the cabinet secretary, and that ability to pay attention was very challenged. And so I have 2 deputy secretaries, and then I have 2 bureaus that report directly to me. The deputy secretaries are Cammie Chapman, who is my deputy secretary for adult and child programs, the Bureau for Social Services, which is the bureau that has CPS, APS, foster care, adoption. All of those programs are within the Bureau for Social Services. The Bureau for Child Support Enforcement works very closely with social services, and that is the bureau that both enforces orders, collects child support, works on paternity, etc. My other deputy secretary is Christina Mullins. Many of you may know Christina Mullins from her previous stints in maternal child health, and also as the Bureau Commissioner for Behavioral Health. Christina is my deputy for mental health and substance use disorders. And so both the Bureau for Behavioral Health and the Office of Drug Control Policy report into Christina. In the 2 bureaus that report directly to me are the Bureau for Medical Services, or Medicaid and CHIP. and then the Bureau for Family Assistance, which is where all of our support programs lie. So SNAP and TANF and childcare in particular lie within the Bureau for Family Assistance. This is a very talented group of subject matter experts who are in the role of commissioners in each of those bureaus. I will say that this needed to be updated. Dawn Frona is no longer with the Bureau for Behavioral Health, so we do have a vacancy in that commissioner role. Christina Mullins is working. She is not being appointed as the interim secretary, as she doesn't need one more title. The interim commissioner, excuse me, she does not need one more title, but she is working with that bureau to sort of prioritize and see exactly what we need going forward for that bureau. So Christina is probably your go-to, in addition to Cindy Bean, who is our longtime commissioner for Medicaid, Bureau for Medical Services. But also I want to talk a little bit today about the work coming out of the Bureau for Family Assistance, and we'll talk a little bit about social services as well. So I'll have the next slide, please. So just so that it gives you some perspective, this is the largest department of the three. So our total departmental budget request for fiscal year 2025 is about 6.8 billion. My husband listened to my budget hearing and asked me who put me in charge of that much money. And I said, I think they knew how good I was with money, and he kind of laughed. So anyway, the total budget is about 6.8 billion. The vast majority of our budget is federal, both federal revenue directly, as well as some block grant funding that comes in to a variety of our bureaus. We also get about 543 million of appropriated special funds from the legislature, and also about $1 billion in general revenue. So that's the total overall budget. Regardless of how you look at it, it's a lot of money. It's a lot of investment, both by the federal government as well as the state. And so you'll see that as I talk about my priorities, a lot of them are to really be able to document that we are being fiscally responsible with all of that, all of those dollars. So I'll take the next slide. So these are my priorities as that we set pretty early in the process. Today, I'm going to talk to you through just about the first 4 priorities and talk to you about what we're doing. The rest of them are all supportive strategies for these or supportive priorities for all of these. And we don't have time to go into all of those today. So we're just going to focus on the first 3 or 4 today. And so the first one is really, and I'll take the next slide because we'll go through each of these individually. The first one is really about prevention. Oops, so forget that. Let me not go into the first one. Go ahead, Elizabeth. You can go forward again. Oops, nope, go back a couple. There you go. Stay right there. So this is kind of how we've envisioned what it is we want, where we want to focus in the department. And this is really about our desired future. And so what our desired future, and so when I start to talk about those priorities, you won't be surprised. Our desired future is that we do a lot of work related to prevention, that we do work related to service enhancements, but our focus really is on prevention, and that the direct care that we provide is really through grantees and partners, and some of the bureaus do some direct services. But in terms of the department, our big focus is really on prevention and then enhancements of the services that we provide. All of the things that you see in the blue blocks are really about what it takes to get there. So of course, investment, financial investment, leadership development, and we're talking about leadership development at all levels of the organization. We need to have a workforce, and You'll see that in our priorities. And also that we will make this an employer of choice environment. So I don't have a whole lot of time to talk about what we're doing there, but we are trying to make this environment a place where people want to come to work, but they also want to stay and continue to work. On the right side, what you see are kind of the things that's going to take: collaboration, automation, communication, and accountability. And along the bottom, really where we're investing, and that's in data systems and continuous quality improvement, and eventually moving into quality-based payment. And so that's kind of the direction that we're moving. If I could have the next slide. Now I'm going to talk about the priorities. So in terms of a cross-department prevention agenda, I don't think it's a surprise to any of you that we do a lot of saving when people are way far down the stream, right? And we do a lot of intervention there. And we really want to focus our efforts on trying to get people upstream and to really keep them from becoming further involved, further enmeshed, further further engaged with our systems, right? So I tell my people we want to work ourselves out of a job. We want to be sure that we are providing investments in families so that families can stay together, they can be successful, they can be self-sufficient. And so that goes with behavioral health, it goes with physical health, it goes in terms of how we work with children and families, and how we work with people who have been impacted by substance use disorder. So I've highlighted a few here. I'm going to talk about a few of them. And the first one, as I said, I was going to mention the importance of the Family Assistance Bureau. We have invested in family support centers across the entire state. So we have 2 counties that are still left who don't have family support centers, but we are working on those as well. And basically, family support centers are designed to facilitate family health, basically through whatever that community needs in their families in terms of providing support. So it could be parenting classes, it could be access to certain services before you're involved in the system, like a food pantry or a hygiene pantry, or it could be things like home visits and in-home education for families. It could be hooking them up with programs for education and training that lead to self-sufficiency. So what we know is that all of these protective factors, if we are able to engage families and develop these protective factors, they've been shown to prevent abuse and neglect. We are never going to child welfare ourselves out of the child welfare crisis. We have to go upstream, and we have to really support families so that we can prevent abuse and neglect. And so that's our goal. And the family support centers are a very first step in that. Some of them have been in place for a fairly long time. Some of them are brand new. I would urge you to look on the Bureau for Family Assistance website and find the family support center that support the families that you work with, because they are there to do that prevention work. We are going to continue to expand those population health initiatives in Medicaid that have been helpful in improving health outcomes. Really looking at evidence-based services across the continuum of care for children in custody, and move those children across levels of care that will eventually return them to the community. So we are working very hard on keeping kids out of any kind of institutional care and keep them in the community. Our children with severe emotional disorders waiver is designed to do just that. It's surrounding the child and the family with services in their home, with their family, or in the community in order to keep them from moving further downstream in the system and ending up, out of state residential care program. We are also looking at how we strengthen and expand prevention resources for SUD, expanding those successful pilot programs. We have a lot of programs that are coming out of the Office of Drug Control Policy and the Bureau for Behavioral Health that have been successful in pilots. So how do we take those to the next step? I will say that, especially in our Bureau for Behavioral Health, we've depended a lot on federal grants. That's not necessarily the way we want to build our programs. Get them started on federal grants, but think about how we can then sustain them. So I'll give you an example. We're using mobile crisis units that were paid for through grants to the Bureau for Behavioral Health. We have recently received the approval from CMS to allow us to bill Medicaid for mobile crisis services. And so consequently, what we're trying to do is trying to continue to sustain those successful pilot programs that, again, are preventing people from going downstream. And the last one is that I'm just highlighting here, and there are many, many more, but it's to build that certified community behavioral health clinic model for West Virginia, reduce that reliance on emergency rooms and hospitalizations, which, just as a high level review of some of the services, crisis services available 24/7 across the state, a comprehensive array of behavioral health services so that people are not piecemealing that together, and care coordination to help people navigate both behavioral health as well as physical health, social services, and other systems. We're in the process of, we have some pilots going on with the Certified Community Behavioral Health Clinic. We'll be applying for a demonstration grant that will allow us, if we are successful, to have an enhanced reimbursement rate for those clinics. And I did notice there was a question from you, from someone, about any plans to restructure the comps because of the growing number of licensed behavioral health centers. This is what we're trying to do, is trying to help the comps as well as others become certified community behavioral health clinics that can provide a continuum of care that's available and keeps people out of hospitals. Can I have the next slide? Just some other things. We have a children's crisis hotline in addition to the mobile children's crisis unit that any family can use, again, trying to prevent involvement with the system. We're remodeling the residential care model for children. We're doing some rate enhancements. Again, this goes back to workforce, and that's for some of our services in the Bureau for Social Service. I'm not going to go through each of these, but really focusing on prevention in every single one of our bureaus. Next slide. So the next priority was really to optimize services through continuous quality improvement. And so we have been focusing a lot over the last 7 months on how we introduce a continuous quality improvement model into every one of our bureaus. We do have some bureaus that already had a model in place, but really it's about systematic collection and review of data that allows us to really improve our care in an ongoing and continuous basis. What we have found is that, what I found when I first came here, is we do a lot of reporting, we do a lot of data collection, but we don't do a lot of use of that data to improve our programs. And so this is really what this is designed to do. All of you know about continuous quality improvement. We're introducing that culture to the Department of Human Services. Next slide. This is our model that we're using. It's pretty straightforward. It's a Plan, Do, Study, Act, or PDSA model. And we are just trying to optimize the services, look at where the problems are, what are we trying to accomplish, what are we going to, what are the options, and how are we going to continue to use this model to improve our care. As you see reports that start to come out from us, you will start to see some of this included in reports. It frustrated me when I first came, is that I would see a report and it would have a lot of data in it, but it would never say what we did and how we use the data. So for transparency, this will be a part of what we do in every report. We are looking at a department in our shared administration office, which is the back office for all three of the departments that were formerly DHHR. We're looking at whether or not we pull quality and continuous quality improvement out into its own office that supports all of the bureaus. Next slide. I'm conscious of time, so I'm trying to go quickly. This is our leadership team, and what I'm really trying to do is invest in a very strong leadership team, but also to empower them to look at effectiveness and look at their services in a fiscally responsible manner, to stop doing things that don't work, and to do things that are going to move us forward with our goals. So this is the team who is implementing that. And I will say that this is a great team who has been very open to change and open, and I'm not only open to change, but really are engaged in change. Next slide. So the next one is accountability, and this is where I'm going to talk a little bit more about, you had asked a question about whether there were bills we're monitoring, but it's really instilling that culture of accountability. And so this is really about evaluation of impact. So I said earlier, and I'm just going to focus, say, on behavioral and the Bureau for Behavioral Health. I said we get a lot of federal grants. We get a lot of grants from SAMHSA. SAMHSA is famous for asking how many people we served, what their gender is, what their education is, what their race is, but not a lot about how they were changed by the services that we provided. That doesn't make that wrong, but as a department, we have that responsibility to look at what the impact is of our services on the people that we're serving. So we are now in the process of developing, identifying key outcome measures, impact measures for all of our programs. And so if you're a grantee, for instance, of the Department of Human Services, you'll see that in your statement of work. You will have some outcome measures that you will be accountable for. We will be using, as much as we can, national benchmarks to gauge our progress. But I will say that this is a culture shift for the organization. And so we are working on it. You asked if there were any bills we were monitoring. House Bill 4595 grew out of this initiative. So it is about performance and accountability within the three departments, and will actually require, if it's passed, will require each program in each of the three departments to have a performance and accountability measures for their programs. I said it first, they followed up with a bill, and that's fine, but we're going to do it regardless of whether the bill passes. Next slide. Some hot topics, and there were some that were on your list, and so I'll just mention those to you. You know that we're undergoing a Medicaid unwind, which is basically the fact that during the pandemic we weren't allowed to remove anyone from the Medicaid rolls. So starting in April, we began that unwind. The federal government lifted that requirement. And so we were up as high as about 680,000 people on Medicaid as of the end of December, we were about 532,000 people. It's been a huge undertaking to get everyone evaluated. And if you don't qualify for Medicaid, you are off of the Medicaid rolls. I will say that we do have a Medicaid shortfall. If you haven't heard that, I'm sorry. We have probably about $100 million shortfall, although we got some information this week that it may be only 89 million. But that shortfall is due to a lot of things. It's due to the fact that during the pandemic, we had so many more people, even though we had an enhanced federal match rate. That federal match rate has now started to decrease, and every time it decreases, our state share goes up, and our state share has has fallen short. So we do have a request for that shortfall to be fixed during this legislative session. Child welfare, of course, is a hot topic all the time. You know, I think we're doing much better than we were previously. Our vacancy rate in child protective service workers has come down from last January at 33% to this January at 17%. Still not acceptable, which is why we have a workforce initiative here. But again, making this a place where people want to work has a lot to do with that. And so supporting our workers, investing in our workers is something that I'm working really hard on. Concrete assistance, benefits, and accountability. There's been a move in the legislature this year to try and do things like make people work if they're getting food stamps. And so keep an eye out for that. I'm not going to say a whole lot else. And then finally, SUD waiver outcomes. We are trying very hard to document the outcomes of the SUD waiver, but I will just say there are people in the legislature who believe we've spent a lot of money and not gotten a whole lot of outcomes. So that's a hot topic for you to be watching out for. Couple other things, and I'll just take the next slide, that you had asked, and then I'm going to stop and let you have time for questions. Xylazine test strips, will they be decriminalized? So Senate Bill 209 was actually signed into law by the governor, and it includes now all test strips are decriminalized, and that was effective January 26th. It was effective upon passage. So that's good news. I talked to you about 4595. One of the things that you had asked about was whether or not we still need to follow the OFLAC rules that were in place when DEA required waivers to prescribe buprenorphine. And yes, you still need to follow the state law. The OIG, the Office of the Inspector General, or OFLAC, could probably answer better questions for you on that. But as of right now, you still need to follow the applicable state law. I'm going to stop there because I know you might have some questions, and we have about 10 minutes, I guess, 9 minutes. Tried to go as fast as I could.
You did great. Thank you so very much. We truly appreciate your time and your presentation. So no worries. Does anybody have any questions or comments?
One thing that I've gotten more and more interested in my work in the addictions field are the social determinants of health. And so I'm interested in, are you directly trying to impact the living conditions and working conditions of people in our community? And what is your thoughts about that?
Yeah, absolutely. Thank you for that question. That's a great one. So this is really a part of our family support center's work, is how do we really address those social determinants of health? And so one of the things that we have done is we're getting ready to finalize a contract with the Joint Interagency Task Force, which was a joint government agency during the pandemic to really deal with vaccines and testing. But because they've worked very well together and established a lot of supports across the state, they're going to be going into every community and doing sort of an assessment of those communities and what are their assets, what are their needs, and be able to really look at those what's in place for those social determinants of health, like housing, like transportation, and food and other issues. So we're going to have a really good, I think, inventory of those things that will be informed not only by focus groups, but by our MCOs who are working in those areas, by some other groups like West Virginia 211, who has been working in this space as well, and what the needs are that they've identified. Find Help is another one, all of which have said, yes, let's work together and identify what those needs are. And then we can start to try and fill those needs for concrete supports. So yes, we're working on it. The other thing is that we have allowed our managed care organizations to count any investments that they make related to social determinants of health in communities against their medical loss ratio, which is a standard that they have to meet in terms of how much they spend on services. And so you'll see some areas where they have done a lot of that work. And they're piloting programs in communities that will hopefully be able to address some of those social determinants of health.
Wonderful, thank you.
Thank you so much for the question, Dr. Hirschler. Anybody else have a question for Cynthia?
Yeah, I do. I have a subscription to the Washington Post, and I just read an article today that talked about how in some states, Medicare is reimbursing for things other than medical care, like food and things like that. And I think all you have to do, and I don't know which states they are, but I think the Biden administration has some kind of program that you can sign up for that will allow Medicaid in your state to reimburse for those other things. I didn't know if Cindy, if you knew anything about that at all.
So I don't know exactly the program that you're talking about, but it's probably some sort of a waiver. Medicare has certainly done that in certain situations, for instance, with the elderly and the PACE program within Medicare, which allows them to do some of that reimbursement. But I will say that our Medicaid managed care organizations do have some of that ability to be flexible with the way that they spend their money to keep people from going downstream. So you will see some of that happening in our Medicaid managed care organizations. One of our I think I saw Sheila Kelly on here. The health plan, I believe, is doing a pilot in one county with DoorDash, I think, that is bringing food from food pantries to people using DoorDash. And so trying to make use of, disruptors in trying to solve some of the problems that we are experiencing. So the Medicaid managed care organizations have a fair amount of flexibility in being creative with the way that they provide care.
Nice, thank you.
And about 440,000 of the 530,000 people in Medicaid are in a managed care program.
Excellent question. Thank you so much, Nancy. We have a little more time, so feel free to ask another question or chat it in if you'd like.
I would also invite you, if you have particular questions, you can reach out to me anytime. I try to answer all my emails before I go home or after I eat dinner. So usually I can get back to you pretty quickly unless I don't know the answer, which that means it'll take a little bit longer. But please don't hesitate to reach out if you have a question, you don't know where to go for something, a particular problem. I was listening to your case, and non-emergency medical transportation with Medicaid is absolutely an option for your second case. And in your first case, Jen, I just wanted to offer that our state laboratory services could also perhaps do some more in-depth looking at some of those issues that you're experiencing. We had a particular problem with someone who was going to a day report center and doing drug testing that was showing up as false positives, and our lab services were able to really delve into that system and be able to help with that. So we're happy to help in any way that we can, and just consider that you now have my email address and you can reach out to me if you need some help.
Oh, thank you so much. That's excellent. Go ahead, Jen. Sorry.
Yeah, thank you very much. And thank you for the presentation. It's really great to hear. And it's comforting to have you at the helm.
Thanks, Jen. It's good to see you. It's good to see a lot of familiar faces on the call.
Thank you so much again. We really appreciate your time. All right. Again, you can reach out to us or Cynthia if you have any further questions. My only announcement is the next time we'll meet will be on the 26th. and we'll just have a session of cases, and our car student will also be presenting that day. So Peyton will be presenting, so we're really excited about that. Anyhow, hope you guys have a great rest of your week, and we'll see you soon.
Thanks all.